Hello, everyone. My name is Rajeev Muni, and I have an amazing panel here from all over the world to discuss myopic traction maculopathy, which is a pretty challenging condition. You know, we see these patients in our clinic, and I think a lot of times we're not really sure what the best options are in terms of observation or vitrectomy or macular buckle. So I have a wonderful panel here today, and I was just hoping you guys could start by introducing yourself.
Thank you very much. My name is Jaime Rosales. I am from Mexico.
Hello, everyone. I am Barbara Parolini, and I work in Brescia, Italy.
My name is Francyne Veiga Cyrino. I'm from Brazil.
Hello, my name is Eleonora Lavaque. I work in Buenos Aires, Argentina.
Okay, great. Well, let's dive right into it. I think the first question really is for the average retinal specialist who sees these patients in their clinic. What's your approach to diagnosing them? How do you classify their disease, and how do you think about who you're going to observe and who you're going to treat?
Well, I think that MTM disease is a multifactorial complex entity. There are different things that we have to have in mind in order to treat these patients and also to diagnose. There are different surgical issues that we have to have in mind during the procedure, for example, and also to perform an OCT is quite important in order to see at what stage you are treating the patients.
What about visual acuity? How much does that impact your decision? Because a lot of times we see an OCT and it looks terrible, but the patients may be seeing 20/25 or 20/40. And considering that traditionally, you know, we are pretty passive about treating these conditions, most of us, how aggressive are you in managing them, in making a decision to operate?
Actually, I use, of course, the staging disease because I've been studying these patients for a very long time with a very long follow-up, studying the evolution of the disease itself. And I have seen there is a pattern of evolution that is always the same, very repeatable, and they all goes from one stage to the other in time. And the stages means that they start from having the schisis in the inner layer of the retina, then the disease goes into the outer layer of the retina, and then from schisis they switch to detachment of the fovea and then to total detachment. So if they have very good visual acuity, I don't force them to go to surgery. However, since I know they are going to worsen, I advise them frequent follow-up. That could be 6 months, I think, is wise.
Let's say that you have a patient who has, you know, the beginning of a macular detachment, very early stage, but they still have decent vision. So are you suggesting surgery in these cases?
Yeah, I base the surgical decision on OCT at that stage. So if I see that they are switching to retinal detachment, I advise macular buckle. Because I already know that quickly they could evolve not only to full detachment, but also to a full thickness macular hole. And that's much tougher to deal with. So I think it's wiser to do surgery. But that's all linked to the idea of having an available surgery and a relatively safe surgery.
Can you, Francyne, just comment on the traditional approaches here, you know, particularly vitrectomy and now more emphasis on macular buckling? How do you make a decision on how to use which one or both in your practice?
Nowadays, what I consider is the axial length. If the eye is so big and you have a very big staphylomas, perpendicular traction and also anterior posterior traction, and so when you have all of this, and the staphylomas is so big, sometimes when you do the vitrectomy, the retina doesn't stay attached. So I think macular buckling to push the sclera through the retina, it's a good approach. So I really consider this in eyes more than 29, 30 millimeters of axial length.
Barbara, some of the OCTs that I've seen recently you present about where you see such a huge staphyloma and the retina is like a trampoline, when you see those images, you know, you really do question yourself, like, why am I considering a vitrectomy? Because the retina doesn't want to return in that position. So a gas bubble is only going to be a temporary effect. Do you want to also comment on the same question regarding vitrectomy?
Yeah, I would like to say that those are the one that I call scleral detachment, and not retinal detachment, because it's the sclera elongating and actually detaching from the inner layers. At this point, I don't want to make the decision based on the shape of the staphyloma, because it is too difficult to decide and there's no correct guidelines on judging a staphyloma. We have ultrasound and we have wide field OCT, but we don't have a geometrical guidelines and threshold on the shape of the staphyloma or the length of the radius of curvatures. Those concepts are too difficult to be applied in daily life. So my advice is, if you want to close a hole, lamellar macular hole or better full thickness macular hole, you have to go inside and do endobulbar maneuver, ILM flap, or whatever you have available. But if you want to treat the schisis and detachment, definitely you have to treat the sclera and buccal from behind. I suggest actually to start with the buccal and treat the detachment, because then you return to just a macular hole, which is much easier to deal with.
Stage the surgery.
I stage the surgery because sometimes when they have just a macular hole, most of the time they don't even need to close it, because they can gain a very good vision, or they might have atrophy. So you might not judge that it is necessary to go to vitrectomy and really close the hole.
Right. So when you have a macular hole with good vision, no detachment, you may just observe these patients.
Observe.
Yeah. So, Eleonora, I wanted to ask you about the treatment with macular buckle. So if a surgeon is trying to start this procedure and learn how to do it, what are some of the tips that you would give them on technique, some of the common mistakes that you might make early on, and how would you advise them?
When I tried my first time with all the equipment and all the papers read to do it, I couldn't. I handcrafts the buckle. So I think it has a learning curve, the position of the buckle, the indentation of the buckle, the height of the indentation. It has a little curve, it's not so long. And as I told you, my first attempt, I could do the buckle by myself.
You were able to do it on your first turn.
Of course, you read, you take measures, you have your study, your previous study, but in my first attempt, I could.
Can you go over the technique very briefly?
The handcraft buckle is easy. It has a titanium stem inside and a sponge. The size 2 centimeters by 1, and you shape an L. And then you position that L in the temporal, superotemporal quadrant, and this part is the one that has to indent the macula. So this is the tricky part. You put the direct lens, and you have to look and see the indentation in order to see if you are in the right position. So, for example, Barbara today gave us some tips, like take a picture of that macula, put sun mark where you want it to be, because it's really easy to get lost in the dimension and all the tissue. Really, the staphyloma makes many changes in the posterior pole. So with that in mind, you look the picture, you look through your microscope lens and see if it is in the correct position. In that moment, you are sure that you are living there, and then you close the conjunctiva, and if you put it really far away from limbus, like 12 millimeters, 15 millimeters, you are okay. So my first buckle, I had to take it out, but then I found 4 more patients, and they did beautifully. Different to phacoemulsification or vitrectomy itself, I think the handcraft of the buckle is not difficult, and the position and the choosing of the patient has a little of a study, but it's really not difficult.
It sounds like placement is really the key here. So what are your tricks?
I started to study this disease in 2007, and since then my efforts were always focused on how to improve the design of the buckle, and how to make it easy, because worldwide this technique is thought to be very complex, and that's why the surgeons don't insert them into their daily practice. In the past, I was trying to create my own design, and I worked with different prototypes, and then in 2020 I switched to an already available product, and their initial design was not exactly what I thought easy, so I tried to redefine the design to make the surgical strategy reproducible. So nowadays there is a surgical technique which is described and published step by step. It's a 30 minutes procedure under local anesthesia. You isolate the temporal and superior muscle, you measure where you want to place the buckle, you can connect the buckle itself to an instrument, a loading device that helps the insertion and the placement of the suture and the final checking, and then you place the suture into holes, which is much easier than going around the buckle. And then you have to check. And as Eleonora mentioned, the key step of the whole surgery is to make sure that the location of the buckle, centration of the buckle is correct. We should avoid paracentesis, we should avoid sclerotomies, even we should avoid to place lights into the eye to avoid sclerotomies, because opening the eye opens the way to the risk of having complications like hypotony and choroidals. You just place the lens, check, and close.
And under the flat lens, can you
can see
the indent?
Just the flat lens and the microscope
You can
light.
see the,
because of the shape of these eyes, you can see directly the fovea.
Right.
You have to move the buckle to make sure that you're seeing the buckling effect.
Right.
And that tells you exactly where you are. Also, to make it easier, especially during training, you can insert a light into the head of the buckle to use transillumination to guide you. It's not mandatory, but it's helpful in the first surgeries.
What we do at our first case was to do an ultrasound during the surgery. I would like to be sure that the buckle was under the macula, so I had the previous one, and then I saw that it was flattened, and it's a good point too. And also the illumination, but sometimes you don't have a chandelier. I know avoiding getting to the eye, but the chandelier is so thin that it can help you to see if this slight movement, if the buckle is under the macula, and you have to be gentle not to avoid some hemorrhage or something like that.
I think we can accept a chandelier because like 29G, I mean, we do it also in retinal detachment surgery. I would not recommend the paracentesis, and I'm saying that because for many years I have done it on purpose, because I was thinking that lowering the pressure would allow me a better indentation. And then I realized that that was putting me at high risk of having choroidals. I didn't have major choroidals in many patients, but I had one. It was more than enough not to repeat myself.
It's also important to see how high is the indentation. So that's another
Tricky tip, yes.
tricky tip. Well, in the handmade device, you need to put two sutures and then try to put another one in order to create a more higher indentation in order to achieve what you're trying to do with that surgery. So
Well, however, I must say that achieving a high indentation is what you're looking for, especially at the beginning, because you want to make sure that the buckle is there. Otherwise, we should not change to shorten the axial length more than 1.5 millimeter. No.
So it may be very subtle.
It's subtle, it's enough, because then you will notice that with the time, not immediately, the retina will settle on the sclera.
Sounds like scleral buckling in general. You know, I think a lot of times we think we need to see an indentation, but it's always less at the time of surgery, and the next day you can see a great indent. So have any of you had any complications? I know Barbara mentioned choroidals. Can you speak about some of the complications that you've had?
My first case, I put the buckle, everything was perfect. I did the paracentesis, and I had choroidals.
Like choroidal hemorrhage or effusion?
Hemorrhage. And I saw perfectly the veins in order not to be closed. So I simply take it out, and the vitreous hemorrhage resolved.
Can you explain? So why would you get a choroidal hemorrhage if you're not going into the eye, other than the paracentesis?
I would like you to tell me, because I try to prevent them. But as you and I know, these kind of patients, they are more propense. They tend to have more choroidals than the rest. So I don't know if this paracentesis decompression lowering the intraocular pressure, but I did have, and not only in that superotemporal quadrant, but in the rest. So I have like 4 hemorrhagic choroidal detachment. I scared a lot, but it was my decompression. After that, I didn't repeat the paracentesis. I just put the buckle, and I didn't have. But you know, these eyes has a tendency, even though when you do a phaco or a vitrectomy, even though they are not hypertensive, but you know, they have tendency. So we have learned that when we put an scleral buckle, we have to reduce the volume, because volume is not compressive, air it is. So that is the thinking why paracentesis was at the beginning of the technique.
And you did the paracentesis first, and then you placed the buckle after? Before?
I placed the buckle, I did the paracentesis in order to indent a little more.
I see. And then you got the hemorrhage at that moment?
No, at that moment. I closed everything, I went home, and when I saw the patient,
secondary hypotony.
Yes, then I took it out and then resolved with another technique, because I wanted it to be with something that I managed completely, like a vitrectomy is what I am used to in the past 25 years. And of course, my patient knew this was a new technique. That is another conversation that you have to have with the patient. So it's new for you, it's new for them. So there are many steps. You have to do the buckle, you have to put it correctly, you have to have the indentation correctly, and you are new also in this.
I have just one complication. That was a supraretinal hemorrhage. But I think it was because it was a very big staphloma. That it was at the posterior pole. So when we put the buckle, it was the reducement was so high. Yes, yeah. And then it was from 32 to 24 millimeters. So it was too much.
So it must have sheared some vessels or something.
Yeah, but I think it's because, I know, these are, of course, the training mistake, because you want to see the indentation, you tend to buckle even more than needed. And the fragile veins in the choroid of those eyes can break easily.
Using an infusion line during the procedure, you don't think that's necessary?
It's not necessary, really. Believe me, the better, the more we keep the eye a closed environment, the better. And again, we don't need to indent that much. You know, the final shape is predetermined by the design of the buckle itself. And I designed that in such a way that I have a final shape which is as much as needed to buckle and to keep the fovea safe forever.
And this one you suture how far back from? It's about 12, is it 12 millimeters or something?
This was the result of a study. First of all, using the same length of buckle, I have studied the correlation between the axial length and where I should have placed the suture. But then I realized that it is not comfortable to suture, let's say, at 18 millimeters.
Right.
And also we should not suture at 8 millimeters, because that exposes you to exposure, the risk of exposure of the buckle through the conjunctiva. So our final goal should be to suture around 12 millimeters, which is a very good distance, not too far, not too close to the limbus. And in order to do so, the buckle will come in a customized fashion, short or long, based on the axial length of the eye.
You pick which one you want, and you do 12 millimeters regardless.
I would say 12 millimeters plus or minus. You have to check.
You have to check.
You always have to check.
So do you suture it, and then you observe, and then you adjust if necessary?
Yeah, what I do, I study, the placement of the suture based on the axial end and the shape. I place one suture on one side. I check.
Yeah.
And if I'm happy with the centration, I place the second suture.
So I wanted to talk about one of the more maybe controversial aspects about these buckles. There was some chatter about the possibility of atrophy. Now, atrophy can occur, obviously, we know, in the natural history, but what are your thoughts on this topic?
We have published that study. We ran a study while I was with Dr. Barbara, and we wanted to prove actually that this was theory or even valid. So no studies have been done to evaluate this, and we gathered all patients we could operated by Dr. Barbara, and we did a comparison between the patients that underwent baclobuccal and high myopic patients with similar characteristics. And we found out that actually the myopic maculopathy is almost the same in both groups during a long period of follow-up. So this is actually, it was actually mildly higher in the control group. So now we can say that there is no atrophy. We had some patients follow up for more than 15 years. So it's a valid and contundent
That is
study.
the scientific data, and I love your numbers. But also, what tissue in our body can support being strength far away, like many more millimeters? I had patients with 38 millimeters long eye. So atrophy will be there. And if you put an scleral buckle, you reduce 1 of 38. So atrophy will be there with buckle and without buckle. It's the same.
It's actually been
It's
studied
the pathology.
that atrophy develops in high myopia. It's been published.
Of course, and we have the testimony of all our patients losing vision without schisis yet or a detachment of the macula just because of atrophy. So it will be there anywhere, whatever we can do. We can solve one part like the detachment, but no the buckling and neither the vitrectomy solve the axial length growth. And they will keep on going to atrophy. So I think it's beautiful. It resolves part of the problem, but atrophy is there.
Now, if we could have the ideal buckle,
Yes.
we should propose it as prevention.
That's right.
Because the key step of high myopic maculopathy is progression of elongation.
Right.
And it's been demonstrated that if you measure the axial length, it will become longer and longer. It doesn't stop at 24 years of age.
You will. In a few years, with many buckles around the world, we may or you
As a
may
prophylactic,
suggest
yeah.
to indent a little more, not leave that eye with 30 millimeters, because we will see the atrophy come, not the detachment, but the atrophy will come. So you may suggest to indent more when we can prove 10 years of buckling, macular buckling without problems. But we need time for these big, huge changes in treatment.
So one aspect is the elongation. I suppose another possibility could be impacting the choroidal vasculature. Have any of you looked at the perfusion after a macular buckle?
I used to study all these patients with fluorescein angiography and ICG. Then at a certain time I just stopped because I saw that I didn't have significant changes. Actually, in fact, if you measure the thickness of the choroid after buckling where you don't have atrophy, most of the time you will find an increase in choroidal thickness for a certain amount of months, for a certain time, and then it goes back to the baseline thickness. So there's no ischemia induced by the buckle.
There's also a study that is running. Dr. Matsui, she told me that she found out that actually the choroidal abnormalities are just at the rim of staphyloma. So when you are reducing the acute angle of staphyloma, then you're also reducing or preventing the abnormalities around the vascularization.
And also with the conventional buckling, the one that we use for a peripheral tear, we do not have any added thing about atrophy in this, and that indentation that we use how many years?
That's right.
50 years. So we have to think like this, different.
Yes. I would like to say that I have so many doubts in my daily practice. When I do retina surgery, when I do a retinal detachment surgery, I never know the outcome. When I do a macular hole surgery, I never know the outcome. I'm always afraid of how the patient will look like the day after. We have, this syndrome, the day after syndrome, right? But on one pathology, I don't have any doubt. To me, MTM is mathematics. Mathematics. It's the only thing that has that kind of logic and repeatability in my professional life. Because whenever I see MTM patient, I already know how they will progress. So if you study the MTM staging system, you will see it's just a matter of time. They will progress according to that type of evolution. And if you place a macular buckle, you just stop the disease and you can feel at ease, because you will see your patient in 10 years and you can tell the patient you will never get a retinal detachment. You are safe for life.
Mm-hmm. I'd like to thank all of you for a very engaging discussion about myopic tractional maculopathy. I feel that it's an area that's evolving, and I think many of us will start moving to a little bit more intervention than perhaps we were used to before. So I'd like to thank you all for all the great work you've done in this area to teach us. Thank you. Do we have any questions from the audience?
Just wanted to ask about the long-term visual and functional outcomes for macular buckles.
Well, I've seen the database of Dr. Parolini. She has more than 250 documented cases. She has done even more. And you see that the long-term follow-up is quite amazing, because the vision stabilizes, and you also have patients who have never had that vision before, and then you return that vision and they are quite happy. And now that you see that there is no such atrophy over the time, then you are more confident to use the macular buckle.
So you have studied microperimetry on my patient as well. So what did you observe?
By using the microperimetry, that it is a more objective tool, you can see that there is a big improvement in the sensitivity, even in spots or places in the macula where there was no any response before the surgery.
I have reliable data collected and analyzed on 265 over 15 years follow-up, and they hopefully will be published very soon. So we analyze the result based on vision, worsened, unchanged, improved, resolved, okay? And anatomical result, same way. So we found that in 95% of the patients, the anatomical result is either completely resolved or improved. And the visual function improves only if they don't have atrophy preoperatively, because, of course, if they have atrophy, you just improve anatomy, but you don't improve function. But when they have no atrophy, you have an average visual gain of 3 lines.
In my experience, I have almost 2.5 years of follow-up of my patients, and all of them are better than they were before, and the vision is stable, and the buccal is stable. We had no atrophy until now, and so I'm very fan of this macular buckling situation, because I've been following Dr. Parolini's steps. And I was I felt it was challenging, because sometimes the first case of mine was a retinal detachment, a lady who had a retinal detachment and was underwent to vitreoretinal surgery and redetachment. So the macular buckle was a very good thing, because the retina stays attached until today, and we could regain vision. So I think we have many applications, not only for the macular hole plus retinal detachment, but also, as she said, preventing the elongation, because the other eye is going to grow too.
Two very quick follow-up questions from a technique perspective. When the macula is detached, is it harder to see the placement of the buckle if it's actually separated versus a more shallow detachment, for example? And second, how do you deal with epiretinal membrane components? So, for example, it's a patient you want to do a macular buckle on, but there's some element of VMT or ERM. How does that influence your management?
I think it's important for the first question to put a chandelier light in the buccal in order to see where you're placing it, because when you have a very high retinal detachment, it's not easy to see the planes over it. Yeah.
One trick could be just indent a little more. You see where you are in the place, and then you go backwards. So you see where you are.
In my experience, we placed the buccal first, and then with the chandelier, and then we checked with the ultrasound if it was in the right place. Then we performed, I did combined surgery in a few cases, and then I do the vitreoretinal surgery, and then I peel the IOM, I dye and peel the IOM, and everything's goes okay.
I tended to do more combined surgery in the past to solve macular buccal. Plus, I tended to do combined macular buccal and vitrectomy to solve very high retinal detachment, especially if combined with the macular hole. I tend now in time to switch to macular buccal only, not to remove epiretinal membrane, because sometimes when there are epiretinal membranes and the retina is detached, you can induce new holes. And if you induce new holes in areas where there is atrophy, they are very, very tough to deal with. So my advice is to just place a buccal. You might decide to inject a bubble of air and place and advise some face down positioning. That will allow you to absorb the subretinal fluid, and afterwards you decide whether it makes sense to go inside and remove the traction or not.
Great. Well, thank you all for a very engaging discussion. I know I learned a lot, and I'm sure the audience has as well. I'd like to thank you all for your attention.
Thank you.
Thank you all.
Thank you.
Woo!